And welcome everyone to another wonderful episode of the Development and Analysis of Human Movement. And this week we will be discussing the hip and the pelvis. You guys should all be done with your practicals now. Congratulations on a great first week. First practical, not first week. You guys did excellent. It wasn't as scary as you thought. But now it's time to get back into the brass tacks. And what I think I'm going to do is I'm going to actually go over the content here. And then we're going to have a lab video so you guys can kind of palpate and work with each other on that. And then next week we'll go have our knee and our ankle video. And we'll also go over in lab everything: hip, pelvis, knee, ankle. We'll kind of hit it all, yes, answer questions, and take it from there. Without further ado, let's get rocking and a rolling. So this week we have, as I said, the hip and the pelvis. Our objectives are to have a general anatomy overview of the pelvic girdle, and we're also going to describe normal kinematic relationship between the pelvic girdle and the hip, and the pelvic girdle and the spine. So what bones constitute the pelvic girdle? Well, it consists of 4 different bones: the sacrum, the coccyx, the left and right innominate bone, which is further divided into the ilium, the ischium, and the pubis. Within this pelvic girdle, there are 4 different articulations within that. We have the bilateral SI joint, we have the symphysis pubis, or what I call the pubic symphysis, and then we have the lumbosacral union, or lumbosacral joint. Okay, so let's go ahead and look, and you can actually see right here that the lumbosacral is pretty much what it, if you break it up, lumbo is the lumbar spine, and sacral is the sacrum, and so that is the joint where those two connect. Then we have the sacroiliac, so that is the sacrum and the iliac bone right here, the ilium, and this is the iliac crest, as we will further learn that this is the iliac crest. So the iliac crest comes around, hits the sacrum here, and creates the sacroiliac joint. Then as we come further around, we see that we have the symphysis pubis, or the pubic symphysis. This is where the 2 ischium kind of come together and create a little joint right here, and there's a little fibrous disc that actually sits in there. And so these are 1, 2, 3, 4 joints of the pelvic girdle. Overall, this pelvic girdle provides attachments for 28 different muscles. So if you notice in the last slide, most of the articulations, 3 of the 4 articulations, all revolve around the sacrum. The sacrum is the wedge-shaped bone that's made of 5 fused sacral vertebrae. At birth, they are individual, but then they fuse shortly after to make the sacrum. There's an anterior and a pelvic surface, and it's a concave surface as well. Okay, so you can see here, this is looking at it from the side. So if I were to take it here, look from right here on the side, you see that that's the concave surface of that sacrum. And then you can see here where the sacroiliac joint is, that articular surface is also concave as well. Okay, due to the tilt of the sacrum as it sits between the innominate bones, the sacrum articulates with the 5th lumbar vertebrae, and that's what they call the lumbosacral angle. We'll dive into that a little bit later, but what that pretty much means is the angle at which this bone right here and this joint sit is called the lumbosacral angle. It really makes up a lot of the postures that we see that are dysfunctional in many of our patients or many of our clients that we will look at. And finally, at the bottom of this sacrum is what they call the coccyx. It makes up the most inferior portion of that sacrum, and it's about 4 little pieces right there. It almost looks like a rattlesnake's tail. And then as we break down the actual context of the sacrum, we have the body, or the base of the sacrum, Okay, so it's right up here. This is the part that articulates with L5. And then we have the articular surfaces that we already discussed that articulate with the ilium. And then we have just a little factoid that the female sacrum is actually wider in the back than it is in the male. And that's really just to help with the widening of the hips during birth, the birthing process. Then if we look at the other bones, we have the innominate bone, which is the giant bone on the side. So if we go back to our original, it's this giant bone right here that we're looking at. Okay. So then we further break this bone down into the ilium, the iliac crest, the PSIS articulation, not articulation, but the PSIS, the PIIS, and the ischium, and the ischial tuberosity. Okay, so what are all those? Because there's even more after that. And that's where we get into the pubic symphysis down here. Okay, so the ilium. The ilium is this giant bone, and the iliac crest is this giant ridge. So when we lay our hands on our hips, that is what we are laying our hands on, is the iliac crest. So you can feel that really right here on our hips, right there. Okay, that's the bony part that you can feel right there. Then we have the PSIS. Okay, that is the posterior projection of the iliac crest, serving as an attachment for the posterior sacroiliac ligaments. So we're looking for the PSIS, and it's right over here. You see this little guy right there. So if you follow that crest of your pelvis all the way posteriorly, this is the anterior. Posterior, you'll feel a little ridge, and it dips. That right before it dips down, that is your PSIS. Then we have the little dip, and then you get the posterior inferior iliac spine, so the PIIS. And that is the articulation where that sacrum kind of sits as well, in that lumbosacral area. That sacrum, you can see kind of, oh, it's a little bit hollowed right here. You can see that's the articular surface for that sacrum. Then we have the ischium, which if you are sitting in a chair while you're sitting watching this wonderful video today, that is what you are sitting on, is your ischium, and more specifically, your ischial tuberosity. And that's the blunt, rough projection that acts as the weight-bearing portion during the seated position. So congratulations, you have found your ischial tuberosity. And then if you look back here, since it's not on the slide, I am going to go over it. I'm sure we'll talk about it later. But if you follow that crest where you did rest your hands on your hips, right? Follow it to the anterior side, you now get your ASIS. And now that little bony protuberance right at the front of your hip, right before it dips down, you will feel your ASIS. Then you kind of lose it, because now we start getting all this soft tissue that sits in there with your rectus femoris and your psoas muscles and your rectus abdominis that all run through there. So you kind of lose any bony palpations anymore until you get to the pubic symphysis. And that's a little bony protuberance right above your crotch, typically. We will not be palpating that in class, but just so that you know you can palpate it on yourself. And then the pubic symphysis, as I was just talking about, is the joint formed between the left and the right pubis. So we have our right pubis here, our left pubis here, and the back is the ischial tuberosity right back there on the posterior side of this, and you can see right here it joins up into the pubic symphysis. And then you have a ligament on top, ligament on the bottom, a fibrocartilaginous disc in the middle, and then in the front we actually have an inguinal ligament. And you can actually palpate that. We can try and maybe do that in class if you want, but we'll see how that goes. It's not really important for us to know. That is where typically you would get a sports hernia, actually, though. So if you do get into PT or anything like that, that is actually what you would be palpating there to see if that is supported or if that is dysfunctional. The sacroiliac joint. If we're looking at it as a joint, it joins the sacrum and the innominate bones, more specifically the ilium, right? Sacroiliac, sacrum, ilium. It's a synovial non-axial planar joint, so the movement is linear versus angular. So the joint surfaces are relatively flat and they glide. Now when I write that the movement is linear versus angular, we'll dive into that a little bit further later when we get into the kinematics and kinetics of the body, when we get into the biomechanical portion of class. The motion occurs secondary to other motions, so you can't really fire a muscle to move your SI joint. It more specifically occurs as an ancillary movement. And the function of the joint is really to transmit weight from the vertebral column to the innominate bones. And it is a very stable joint, however, it does become susceptible to all the torque forces that happen throughout the body as it moves up from the lower half of your body or from the upper half of your body down to the lower portion. Since a lot of our motions that we ask our body to do revolve around rotation, a lot of times this joint does become susceptible to a mild to moderate dysfunction. I'm sorry for the interruption, but we do have a special guest today. My son, little Henry Chico. Do you want to say anything, sir?
Yeah.
What would you like to say?
Hello.
He says hello and
Happy Halloween.
and he says happy Halloween. Wave to everyone.
Hi.
This way. There you go. Blow him a kiss. And say adios.
Adios.
See you later, alligator.
See you later.
All right. So, as we look at the sacrum, we kind of talked about the tilt before, but now we're going to see like what that's actually called. So, there's nutation and counter nutation. Nutation is what they call sacral flexion. So if you look back at this left photo over here, letter A, you see how the top portion of the sacrum is pointed anterior, which would then stick the booty out, right? Because the bottom end points posterior. Okay? So that's what we call nutation. And then counter nutation, which would be tilting it the other way, tilting it back. So let's say this platform is it would be there. Okay, so where the distal portion moves anterior. And that was where the sacrum and the coccyx move anterior. Like I said, both motions can only occur with other joint motions. Okay, nutation is trunk flexion or hip extension is when that happens. And counternutation is when trunk extension or hip flexion occurs. You can kind of see that, like if you stand up and you do hip flexion, so you lift your right leg up, you'll notice that as you lift your right leg up, your butt kind of drops forward when you do that, and you shift your weight posterior so you don't fall over. And then you can see with trunk flexion, you get nutation of the sacrum, where that inferior portion of your coccyx and sacrum move posterior with that. The lumbosacral joint. It consists of the fifth lumbar vertebrae in the base of the sacrum. It's the bodies of L5 and S1 that are separated by an articular disc, kind of like the vertebral discs in our spine. So that's just continued throughout into that lumbosacral joint. And it's stabilized by the iliolumbar and lumbosacral ligaments. So what we have here is what we call the lumbosacral angle. Okay? It's responsible for lumbar lordosis. It is determined by drawing a line parallel with the ground along the base of the sacrum. The angle will increase with the anterior tilt and decrease with a posterior tilt until we have an optimal angle of 30 degrees. So let's take a look here. Our lumbosacral angle. This is a normal lumbosacral angle. We have the parallel line with the floor, and then from there the anterior portion of that sacrum, and how L5 and the sacrum, how they kind of meet. So you notice that with increased lordosis, right, we have nutation, right, happening right here on the middle. So the sacrum is anterior, and then the distal portion is moved posterior. And you see how as that moves this way, it shifts the pelvis or the sacrum that way, thus increasing the lumbosacral angle, because now the top of that sacrum is now anterior, thus more vertical. And then as we counternutate, we get a decreased angle, where now the top portion of that sacrum is more flat, and thus that angle between the floor and the lumbosacral region, it is now more horizontal, thus decreasing the total angle. The function of the pelvis overall is to distribute weight from the top half of the portion, the top half of the body, to the bottom half, or the bottom half to the top half, depending on the activity. The pelvis supports the weight of the torso through the vertebral column and onto the innominate bones through the sacrum. It absorbs ground reaction force from the foot through the lower leg and distributes these forces into the spinal column. It's a triaxial joint with 3 planes of motion, and it provides an attachment for the muscles. So if we go back and we look here, looking at the top to bottom, so this is where our hips would be, right over here, right? So if we're transferring the weight's gonna, or any impact from the ground is gonna travel up through our ankles, up through our feet, up through our knees, and into our hips, and then into this iliac bone here, or ilium here, and that's gonna be transferred from the ilium to the sacrum via the SI joint, and then up the spine. And then if it comes from the top, any force would come from the arms, the head, down the vertebral column, through the sacrum, into the ilium, through the pubic symphysis, through the hips, and down to the feet. So you can see how that forces could be shared throughout that joint. So now we have what we call the pelvic girdle motions, and this is really what we see with a lot of different people, what we'll look at when we look at each other in lab. So anterior tilt. This occurs when the pelvis as a unit is tilted forward. So you can see in object B here, the ASIS is now further anterior. The top of the sacrum is anterior, and distal portion is driven posterior, and you get this excessive lordosis of the lower spine. So you have an increased curve in this lower spine, and this is what we kind of call a little bit of cheerleader booty, where that booty kind of sticks out posterior. Then we have the posterior tilt, where we rotate the pelvis posterior. So the top half, the ilium, are now driven posterior. Sacrum is driven anteriorly, decreasing that sacral angle. And you get more of a flat posterior spine back there. That lordotic curve is now flattened out. Then you can also have a lateral tilt. And this occurs when the two crests are not level. So these two areas here, the left to the right, one is more superior than the other. The pelvis moves as a unit, so if one side moves up, the other side will go down. It's like a teeter-totter system. It's named by the unsupported side, which is the weight-bearing side, and the weight-bearing crest that should be level. And that's how you determine what the lateral tilt is. As the pelvis tilts to one side, the joints above and below it move opposite. So in the sagittal plane, the ASIS and the pubic symphysis are in the same vertical plane. In the coronal plane, the iliac crest should be level as well. So this is what we're talking about here. You can kind of see how the ASIS is what we're measuring with our lateral movement right there. This is a nice level pelvis. But as I drive one ASIS on this left hip inferior, the other on the right moves superior. This is how we are kind of talking about how we walk here. So you see it would be a left slip where the left side is going down because we name it off the right supported side, right? So we have a slip on the right side or the left side on the actual person if we're looking at him anatomically, right? Because if we're facing that way, it's his left side. His left side moves inferior as his right side moves superior. So if we look this way, we can kind of see all the forces coming through him on this picture from looking at him from behind. And we see that right hip is abducting and the right leg is non-weight bearing. So it's abducting, the pelvis is tilting to the right, whereas on the left side, the hip is adducting, because you see here how it's moving closer to midline. And then the left leg is bearing the weight. So you can see how as we walk, we get this rocking kind of motion, because then the same exact thing would happen on the right leg when he goes and he actually plants his right foot in. And we'll look at that more when we get to actual walking and the biomechanics of that. So then also as we're walking, if we took this picture here, and we look at it now from the cutting him in half and looking straight down, you see that we get this pelvic rotation that kind of happens. It occurs in this transverse plane, and we use the ASIS to measure that. So if we look at A over here, you see that in anatomical position, both the ASIS are in the same plane of motion. So it's nice level here in that transverse plane. I have a nice line that goes through both of them. But then as we have number B here, or letter B here, you see that there's a forward rotation on the right side, and that causes this left side of this pelvis to rotate medially around the femoral head. So you see if I post this, what's the best way to do that? Let's use these two objects that I have. Hip, pelvis. So you look at the pelvic rotation as the hip stationary, okay? So on this, the left hip is stationary, and then as I move the right side forward, it's moving medially around the femoral head, because this femoral head is moving this way to create that. You see that motion there? So it moves in as this right leg would move forward. Okay? And then as it moves back, the femur moves anterior or laterally as the pelvis moves posteriorly. Okay? So just once again, look here. You see how as this right side moves forward because it pivots along that femoral head. It moves this way, thus moving medially around that femoral head. And then as it moves back, it's moving laterally around the femoral head. So we discussed force couples a couple chapters back, and this is really present in the hip. So if we look at our anterior tilt, okay, you see that the lumbar trunk extensors pull superiorly while the hip flexors pull inferiorly, okay? And then you can see here, so that's here, okay? Trunk extensors pull up, hip flexors pull down, and that gives us that anterior tilt of that pelvis, okay? So if you were wondering earlier, when we went over this here, kind of what causes that anterior tilt, it is this, the trunk extensors, so the muscles on the posterior side of our spine. Those are contracting and pulling up. Meanwhile, the hip flexors, the muscles on the anterior portion of our thigh, pull down. And that draws this pelvis anterior. Then we look right and we look at this posterior tilt. What causes that? So typically we get tight trunk flexors, or the trunk flexors are contracting and shortening, pulling the anterior pelvis up, while the hip extensors, the glutes and the hamstrings, pull the pelvis, the posterior portion of the pelvis, down inferiorly, thus causing a posterior rotation of that iliac crest. And then as we look at the lateral tilt, we have the right hip abductors squeezing inferiorly, while the left trunk lateral benders, so the ones that do these side crunches here, those pull superiorly. And that's kind of what we get here to give us this kind of swivel, or to maintain our level pelvis. Okay, in this picture he's not level because he's walking, but just imagine what would happen if these were not functioning. The pelvis would just fall and we would fall to the ground as we walk. We are then brought to what we call the true and the false pelvis. Okay, the false pelvis is this bony area here between the iliac crest on the superior portion and the superior pelvic inlet, which is the line here from this kind of symphysis pubis into the top of the sacrum. Okay. And you can see that. And why it's called the false pelvis is because really no pelvic organs really sit within this area. But then that leaves us with the true pelvis, and that's really between the pelvic inlet and the pelvic outlet. So here, between the top of that pubic symphysis and the inferior portion of that pubic symphysis to the tip of the coccyx, this is where all the pelvic organs sit right there. It makes up the pelvic cavity that contains the GI tract, urinary tract, and our reproductive organs. So then I mentioned earlier that the female sacrum is a little bit broader than the male pelvis, and you can really see that here with the pelvic arch. You can see how the pelvic arch underneath that pubic symphysis on a male pelvis is much more concave than on a female pelvis. While the female pelvis is still concave, it's much wider here. And that's really for that birth canal. You can see how this is a much larger, more shallow bowl to allow the carrying of a child, whereas a male pelvis is a little bit more narrow and it's deeper. So then we have the hip, and it contains all the bones in the pelvic girdle with the addition of the femur. It's a ball and socket joint. Unlike the shoulder, it's very stable with a concession of mobility. It's convex. It has a femoral head and a concave acetabulum. It's triaxial, which means we have three motions within the hip. We have flexion, we have extension, we have abduction, adduction, internal rotation, and external rotation. The end feel for everything but flexion is firm, and flexion is soft due to the thigh muscles and the abdomen touching each other. Then we also have our range of motions here, our normal range of motions. With flexion, it's about 120 degrees. You look here, that's what flexion of the hip looks like, lifting our leg. Extension is about 15 degrees. So as you bring it back, it's really more hyperextension, because true extension is 0 because our legs are together. And we get about 15 degrees of hyperextension. Think of that as the elbow. With abduction, right, we have about 45 degrees. Anatomically, by the way, the hip and the shoulder are very similar, so you can almost think of it as that. Kind of pair those two together. Abduction, so moving away from the midline, away from the body, so right here, we're looking at about 45 degrees. So this angle here, 45 degrees. Then a deduction would be technically 0 degrees. As you bring it to your body, your thighs usually hit, and then you start getting more knee motion there. We have internal rotation. Okay, so that would be this medial rotation, and you see what happens to the foot. The foot goes in, the hip goes in. And we have external rotation. Okay, that's lateral rotation, and that's where the foot goes out, the pelvis goes out. And that is in the transverse plane. So then looking again, as we look at the hip joint, not just the pelvic girdle, we look at the bones again, we look at the innominate bone again, and we have the ilium, the ischium, and the pubis again. But the main landmarks on the ilium are the iliac crest, that superior ridge that we discussed earlier, the ASIS, okay, that was big in looking at our anterior tilts, and that's this right here. As we follow that crest where our hands sit on our hips, pretty much where our index finger would pretty much sit would be our ASIS right here. And then our PSIS in the back, kind of where our thumbs almost sit as we put our hands on our hips. The ischium is the ischial body. That's down here where most of our weight-bearing portion is right there. Take note of the ischial tuberosity. That's in the back here because that's where our hamstrings sit or originate for us. Then we have the pubis, where we have the superior ramus and the inferior ramus, the top and bottom of it pretty much. Okay, superior ramus there, inferior ramus here. And then we have the pubic symphysis right in the middle, where the two joints connect of these innominate bones. Our landmarks, we have the acetabulum. Okay, so that's the deep, right here, red circle that is created. And it's made of the ilium, the ischium, and the pubis, and it's what articulates with the femoral head. You can see in this picture on the left, the ilium has been colored in pink. The ischium is in this beigeish color, and then our pubis is yellow. And so this is our anterior portion, this is our posterior, and this circle here is what the femoral head here will articulate with as it moves around. So just as we had the glenoid up in the shoulder, we have the obturator foramen, and that's the large opening between the rami of the ischium and the pubis, and that allows passage of blood, vessels, and nerves. So it's there. The femur here, we look at the head of the femur, the articulation between the femur and the pelvic girdle. We have the neck, which is the long portion here. We have the greater trochanter. That's the really bony part of our hip that you can feel on the side of your body. So if you feel the arch of your hip bone with your hands, if you follow that down, probably pretty much just take your hand and move it from here and rotate it down like that, right where your index finger is. That's pretty much that bony part. That's the greater trochanter. Okay. Then the lesser trochanter is the smaller projection located medial and posterior to the greater. Can't really feel that one too much, to be honest, so don't worry about palpating that or looking for that. It's not like the greater and lesser tubercle in the shoulder. You can't really feel the lesser trochanter very well. You can see how it's really kind of in there. So it's tough to feel. And then we have the angle of inclination, and that's the angle between the shaft and the neck of the femur, and that's about 125 degrees. So you see here, 125 degrees. Okay, at birth, that is about actually 170, so it's almost even more straight up. But then as our body becomes weight bearing, when we start walking, this kind of levels out, and you lose about 45 degrees of that as your bones start to adapt to carrying the weight of your body. The hip has many ligaments that help create the capsule of the synovial joint that is the hip. It's covered in a capsule, and it's strong and thick fibrous synovial ligaments, and it wraps around the acetabulum to the neck of the femur. The main ones that are connected in the joint capsule are the iliofemoral, and that reinforces the capsule anteriorly from the ilium to the acetabulum. The pubofemoral, and that spans from the superior pubis to the neck of the femur. And then the ischiofemoral, and that's the posterior ligament that spans the ischium to the femoral neck. Okay. Then we have all three ligaments are covering the femoral head and neck in a spiral manner to limit hyperextension. of that, so it's almost like a torqued up spring if you think of it. It's a spring that allows some movement into flexion but not hyperextension. That as you move into hyperextension, those ligaments really tighten up, almost like a Chinese finger trap. If you remember those as a kid, that's kind of what happens to help increase some stability anteriorly in that uh, ball and socket joint. And then lastly, we have the iliotibial band, which is a long tendinous portion of the tensor fasciae latae that goes from the TFL, the tensor fasciae latae, down to into the glute maximus and runs down into the tibia in the lower leg. So just like we have the labrum in the shoulder, we also have the acetabular labrum, and that is helps deepen the socket of the hip and really kind of helps encapsulate that. However, it's much stronger than the shoulder labrum. And that is it. So as you can see here, we're going to go into the muscles next, but we're going to go ahead and hold off and make that a separate video, kind of break this up for you guys, allow you guys an opportunity to go back, review some of the pictures. I know I didn't talk about all the things on all the slides, but they are there, especially on this slide. I didn't talk about all of these, but they're little factoids you can go back, watch, take notes of, and move forward. I talked about the main points that when we get to the palpation portion of the class, you will be able to really dive into. Alrighty, I will see you guys soon, and you guys take care.